theme is how I do it. The moderators for this webinar are Dr. Kishore Chaudhary from Sheffield, UK, and Dr. Ranjit Deshmukh from Pune. We have eminent panelists, Dr. Matthew Abraham from Ernakulam and Dr. Shailendra Achwal from Hull, UK. For this webinar, we have speakers, Dr. Dattatreya Muzamdar from Mumbai. He will be talking on anatomy and trans-ciliary approach. Dr. Ali Asgar from Mumbai again. He will be talking on neuromonitoring and transopercular approach. And third speaker is Dr. Manas Panigrahi. He will be talking on comparative of both approaches. So with this short introduction, I would like to hand over to moderator Dr. Ranjit Deshmukh and Dr. Kishore Chaudhary. Over to you, sir.
Kishore Chaudhary sir is online.
Yeah, is Ranjit not here?
Sir, he is not able to join. Means trying, but some problem.
Oh, right. Okay. So I think without wasting any time, all the three speakers don't think need any introduction. All of us know Dr. Dattatreya Muzamdar, who has been a pioneer in neuro-oncology, field of neuro-oncology, and also Ali Asgar as well, who has done excellent work in Tata Memorial for over last 2 decades. And we all know Dr. Panigrahi as well, initially from Nizam and now in Krishna Institute in Hyderabad, who is very well known for skull base and vascular and oncology field. Our two panelists are Dr. Abraham from Ernakulam, who we all know has special interest in the field of gliomas and insular gliomas, and Dr. Shailendra Achwal probably needs some introduction because this is for the first time, I think, as far as I'm aware, Shailendra, that you're coming into this webinar series. Dr. Shailendra Achwal is a graduate from KEM in 1994, MCH from KEM in 1994, and has been working as a consultant in oncology in Hull for a number of years, for over 20 years now. And he's an excellent colleague, very good surgeon, very good mentor to his trainees. And number of his trainees are now working with us as consultants. And he has got special interest in neuro-oncology, especially in the field of gliomas. So with that introduction, while we await Ranjit to join as a moderator, can we ask Dr. Dattatreya Muzamdar to start? Oh yeah, Ranjit is here. Welcome, Ranjit. I'll hand over to you. Only one request to all the speakers, that can you please keep to the time so that we have enough time for discussion, because I think the discussion that is generated is more entertaining. So with that introduction, I hand over to Ranjit to carry out the further proceedings. Ranjit, over to you.
Good evening, everybody. Thanks to the speakers and panelists. Thanks to Dr. Kishore Chaudhary sir. I can see Dr. Goyal also there. So we would like to start with the first lecture. Dr. Muzamdar will speak on brief anatomy and trans-ciliary approach. Dr. Muzamdar, please.
Yeah. Can you see my presentation?
We can see you're audible.
Yeah, thank you. So thank you, MCNS, and thank you, Kishore, for this nice introduction. And I will start with insular glioma's surgical strategy and philosophy. I would only stick to the anatomical aspects and some part of the trans-ciliary approach. And obviously, then we'll go to the transopercular and the comparison between the approaches by the subsequent speakers. So, as you know, insula is a very, very critical structure, and not many people understand insula. And it is quite okay not to understand insula, because it's a deep-seated structure where within the frontoparietal and the temporal operculum, and unless you make an attempt to see it in a normal brain, you may just miss it. So it is a pyramidal shape structure, and you can see in the cartoon here that it has got 3 surfaces: anterior, superior, and inferior surface. and this is limited by the peri-insular sulci. So this anterior, superior, and inferior peri-insular sulci are very important. It divides it into two parts: the anterior part, which contains three short gyri, anterior, middle, and posterior, and the posterior part contains two long gyri, the anterior posterior, again divided by a posterior central insular sulcus. And this, there is the Lyman insulae is situated at the anterior inferior part of the insular cortical surface, and the landmark is that it represents the bifurcation at which at the bifurcation of MCA. It is referred to as commonly as insular point, and there are several other gyri like accessory gyri and transverse gyri which connect insula to the orbital surface of the frontal lobe. And the most important part, the blood supply, of which we are very, very conscious about, because this is the critical structure. MCA perforators and MCA branches supply the insula, and through that it supplies the basal ganglia and the corona radiata. So there are two kinds of perforators. There are short and medium, which can be sacrificed if they need be. And there are long perforators which are in the posterior superior part of the insula which supply the corona radiata. These are unbelievable. So we have to take every effort to protect that. And obviously, from the arterial supply, we go to the venous. The veins are equally important. I would say veins are more important because the venous structure, the venous edema can be very killing in this patient. So everything might go well if you don't give adequate attention to the veins. The venous edema can cause deficits, and it can be long-standing. It can be disturbing. So the cytoarchitecture, as you see that the anterior insula is more of a agranular structure, and as we go posterior, it is more of hypergranular. And on that basis, it is comprised. It is divided into three zones, and all this from the agranular to the hypergranular zone has got some functions. So as we go from the anterior to posterior, we go from autonomic to sensory to motor. And as you can see, the posterior insula is the most important structure because it is deep. It subserves more of motor function, and that is the crux of insular lesion or a glioma surgery. So here, the insula is well connected, as you know, that to the limbic system, to the thalamus, basal ganglia, olfactory cortex, neocortex. It subserves a lot of functions, as I will come to. And as you see, this is another most important slide. Now with the DTI into picture, you know that it is surrounded by fibers. So the superior longitudinal fibers, the arcuate fiber which connects the Broca's to the vertebrae, the uncinate fibers which connect the frontal to the temporal, and the superior the IFOF and the inferior longitudinal fiber. So all this fiber tract anatomy has to be delineated in any glioma, in any insular glioma surgery. And we need to understand that the medial relations of insula are the extreme capsule, the claustrum, the putamen, and then the internal capsule. So all these things, if you see, are quite important. This is the claustrum. The insular cortex is here, and then you see the claustrum. You see the putamen and the pallidum, and the internal capsule was squeezed in between. So the medial structures of the insula and the lateral surface, it is bound with the mesial temporal lobe structures. So the insula is squeezed between medial temporal lobe and the basal ganglia. So it's a very tiny structure. So we need to pay attention to it. This is the Berger-Sinai classification, Michel Berger from UCSF. And you can see that he has divided insula into 4 zones. So the horizontal, the anterior posterior goes along the Sylvian fissure, and the oblique goes along the foramen of Monro. So whatever is anterior to foramen of Monro, above the Sylvian fissure and below the Sylvian fissure, according to that, there are 4 zones. So zone 1, 2, 3, and 4. So zone 1 is anterior superior, zone 2 is posterior superior, zone 3 is inferior posterior, and zone 4 is posterior inferior anterior. So this, as you mentioned, nearly 40% of the tumors are represented equally between the 2 zones, and 13% of the tumors they extend into all 4 zones. So this is very important, and according to that, the networking is there. So you can see that and the zone 1 and 3 subserves language network. The zone 2, which is in the posterior subserve primary motor and sensory area, as I just mentioned. And the zone 3 and 4 are deep, lenticular striate arteries. And it is very well now established that this Berger-Sinai classification predicts both the extent of resection and the operative morbidity. So this is a widely used classification, and everybody needs to know that. So I will just now highlight from this anatomy. This is the core anatomy. I would like to just highlight surgical management. I will just show trans-Sylvian so that the rest of the people can show the other things. So there are basically two approaches: the trans-Sylvian, only trans-Sylvian, and trans-Sylvian with cutting bridging veins. So there are two approaches in the trans-Sylvian method. A transcortical is through the operculum, which Dr. Ali is going to talk. And as I mentioned, everything needs to be understood when we are encounter with the insular. After understanding the insular anatomy, we have to have preoperative fMRI, DTI. We might do awake cortical mapping, and we need fluorescent guidance for the neuro-oncological control. And the neurosurgeon has to be all equipped with this armamentarium to have a proper surgery. So the trans-Sylvian approach was devised by Gasserger. It is there for decades. So I think there is nothing new in this approach. No, the transopercular is the one with newer approaches. But obviously, when we are all used to open Sylvian fissure always for any cerebrovascular lesions in the vicinity. The anatomy is complex, and the Sylvian fissure anatomy also needs to be understood. And the trans-Sylvian approach has got some indications and some limitations. So trans-Sylvian approach is usually used for patients which have a small to medium tumors, and you have to retract. The vision may not be that great, but it suffices for majority of the insular glioma. You can use the trans-Sylvian approach quite comfortably. Obviously, we are all worried about for that in those cases. In trans-Sylvian approach, usually you are not going through the operculum. So your language network, especially on the dominant side, everything is preserved. You are not affecting the language networks and the facial-motor sensory networks and all that. But obviously, approach to the posterior insula through the trans-Sylvian is a challenge, because the perforators from the branches from M2 and M3, which go deeper to the basal ganglia and the corona radiata, can be a little bit challenging. And for those, the transopercular approach is quite good. So here we need to expose the Sylvian fissure. I will straight away go to some videos so that we get a good idea. So the highlight is that the arachnoid should be incised very carefully. The veins needs to be preserved. The Sylvian vein has to be preserved. The branches of the draining veins, in the small veins draining into Sylvian fissure, usually we can use the open the Sylvian fissure more on the temporal side or the frontal side. You have to disconnect the frontal lobe from the temporal lobe, and you go deep within. So we have to have a understanding, and the working area should be more like a funnel rather than it is like a funnel rather than a cylinder. Because if you go like a cylinder, you have a constricted vision. So if you have like a funnel, you are open to all sides and you can have a broader view. So I will just go to the video, and this will take insular subserves lot of function, as I just mentioned: olfaction, autonomic memory, motor integration, and the most important is that cardioregulatory and vasomotor function, pain perception, biobehavioral. So sometimes insular glioma surgery, if it affects these centers, can produce cardiorespiratory disturbances. And in the post-operative period, sometimes this patient can have unexplained cardiorespiratory functional disturbance. And sometimes I have in my one experience, there has been one patient who has sudden death. So this was completely unexplained. And probably I feel that vasomotor instability was mostly likely the cause. So I will straight away go to the video to just highlight this thing. This is the insular gliomas. Radical resection of insular gliomas. So this is a Japanese paper in 2014. They have said that if the tumor has got clear boundaries, negative enhancement, and intact lenticular striate arteries, intact superior extremity of the central insular sulcus, then these are the practical indicators to identify candidates for radical resection of insular gliomas. So here is the video. I'm just going to shoot two short videos, and you can see that this is the insular glioma. I'm going dissecting right from the proximal sylvian fissure and opening the sylvian fissure in the standard fashion. You can see that the sylvian fissure is widened, and you can appreciate that this sylvian fissure opening is like any other sylvian fissure opening that we do. And you can see that while I'm opening the sylvian fissure, I'm taking care to see that the sylvian vein is kept untouched as far as possible. I'm opening the sylvian fissure more on the temporal side so that you can see the insular glioma is brought into the view. And I also try to open the sylvian fissure on the frontal side as well, so that you can get a view. And you can see that this is a glioma which is exposed after you open the sylvian fissure proximal and coming to the distal. And I remain intra-tumoral, and this tumoral dissection goes. And usually these tumors are soft, suckable. I have not found tumors to be very hard and fleshy and vascular. So most of the time, if I remain within the tumor confines, I know that I'm not damaging anything. And if you can see, after I remove a sizable amount of the tumor, then you can see that there'll be MCA vessels which will coming into the way, and then you have to work around the MCA vessels. So these are the vessels which are M2, M3, M2 basically, and that I will show within a minute. That so here at this moment of time, in this case, I have not used any monitoring. So in some cases where I have seen that the tumor goes into the posterior insula, I use monitoring MEPs and this thing. So you can see here that you can see the vessels. So we work around the vessels, and you can see that small perforators you can take, but not the big ones. But you can see that the vessels are there. I go in because it was a well-defined tumor, just as I mentioned. You could know the tumor-brain interface, and slowly you decompress the tumors, and you can see here I'm going onto the temporal aspect of it now, and the tumor is slowly decompressed, and you can see that this is the main vessel which is there. So you go around, and normally these tumors are normally not that vascular. If it is a high-grade glioma, then you or GBM, then you can expect some vascularity. But otherwise, you can see that as I go, these are the MCA branches. You can see the branches here. So all these branches are kept, and this thing I see the pile surface below, and you can see slowly I can come to the base and get this wide excision, and you can see that I can see the normal brain surface, and actually then line the cavity with surgical, and that's it. Another patient, again, I do the same thing, again a left-sided tumor, again I do the proximal sylvian fissure dissection, and you can see now here the tumor has opened up the sylvian fissure. You can see the clear distinction between the tumor. So sometimes the tumor itself widens the sylvian. This is a classical indication, and the tumor exposes. So tumor decompression, and you can see that the tumor has widened the sylvian fissure, and it has gone more into the deeper aspects also. And again the same principle, and you just remain within the tumor. And if you can see at the end, I see a lot of vessels. So here I'm safely within the tumor. So trans-sylvian approach is really, if somebody has got a limited access to monitoring and this thing, and the tumor is small to medium, can definitely use the trans-sylvian approach. Vis-a-vis, if you go transopercular, you have to have monitoring, and you have to have cortical mapping, subcortical mapping, and maybe do awake. So here you can see the last bit of the tumor. You can see the MCA branches, and you can see the entire circle of Willis from there. You can see the optic nerve, and you can see the ICA and the branches M1, M2. This was a big tumor, and it had completely, it had expanded the silver, and that it was a relatively that way a better better kind of a tumor to do. So that is the end. So I think transfusion approaches are good, and especially when in this region, posterior, if it is going posterior deep, then it's a problem. Then you might have to use this transopercular approach. But it's a left side, so definitely you need monitoring for this. So with this, I think this is my experience in 15. I've done 25 patients where most of the time I've found diffuse fibrillary astrocytoma as a diagnosis. In 2 patients, I had this anaplastic ODG and anaplastic astrocytoma. There was transient hemiparesis in 2 patients in my initial part, where I when obviously because of spasm or something that, and there was in 1 patient it showed an infarction. So definitely you have to be aware of that. And I have a follow-up of 32 months, and all patients, there is no permanent deficit except that patient who had this infarct had some residual weakness. So this is my experience, and I feel that the complications can be very distraught. It can be facial palsy, dysphagia, dysarthria, and immediate and permanent neurological complications have reached. There might be range from 14 to 59%, and 0 to 20%, depending upon the individual, the surgeon, the anatomy, and how you approach the tumor. Thank you very much.
Excellent, Dattatreya. I think we will probably, Ranjit, shall we take the questions now? Or
Afterwards in the discussions, we'll first finish the presentations.
Yeah, good idea.
So I invite Dr. Ali Asgar for his presentation. He is well-known authority in intrinsic tumors, and we all follow his videos and guidelines, and in brain mapping, he has done tremendous work. Dr. Ali Asgar, please.
Yeah, hi, Ranjit. Can you hear me and see my screen?
Yeah, we can already see your.
Okay, all right. Yeah, thank you very much for having me, and thank you, Dr. Mazumdar, for that wonderful talk on the anatomy and Transsylvian. You know, there are 2 sides to every coin. There are 2 sides to every story. So I'm going to flip the coin, and I'm going to talk about the other aspect. Dr. Datta has already talked about Transsylvian. I will talk about the transopercular approach. And at the outset, I would like to say that insular gliomas are quite challenging. And I think though we try to get radical resections, you must remember that more often than not, we'll end up with subtotal resections. It's extending the resection and getting the best and the optimum resection, balancing the morbidity that we are aiming for. So there are many ways to skin the cat. Transopercular, Transsylvian have their own pros and cons, and I hope I can try and show you some of the benefits of the transopercular approach. Essentially, the transopercular is a kind of an inside-out approach. That is, you get into the insula and the tumor and you work yourself out, staying below the pia and not handling the vessels directly. So insular gliomas can be localized just to the insula, but almost 60 to 70% of them have some extension into the opercular. And what we do in transopercular is you get into these, kind of letting the tumor make its make way for you and gradually go resecting that. Resect the 2 opercular, get into the tumor and remove it, keeping the pia intact with the vessels there to minimize the handling. But one of the problems here is that these opercular may have function in them. And therefore, you need to ensure that you are not damaging something which is functional. So you need to do cortical mapping. Dr. Mazumdar mentioned it. And once you map, you'll be surprised very often that you have a lot of opercular windows to get into, both on the dominant and the non-dominant side. And this actually increases your range and your trajectories that are possible. However, it's not just cortical, but once you get into the tumor, you must remember that there are very important subcortical boundaries, fiber tracts. And here I would say that it doesn't matter whether you go transcortical, opercular, or Transsylvian, you're going to reach these boundaries no matter what. And therefore, some kind of mapping, monitoring at these levels is important in all insular glioma surgery. And not to forget, very important is the vascular conflict that you're likely to encounter, especially lenticular striates, where again, some kind of monitoring is going to be useful. So as I said, with transopercular approach, you have more surgical windows and trajectories, especially for certain regions. You avoid the retraction of the opercular, and more importantly, you avoid directly handling the vessels like in the transsylvian. Therefore, you negate the possibility of spasm and therefore ischemic complications. But the biggest challenge and the risk with transopercular is that you're handling or you're transgressing eloquent cortical areas. It's the cortical areas which is what you're transgressing. And mapping therefore becomes imperative when you're doing this kind of an approach. But again, remember that a lot of insular gliomas will be already involving the opercular. And therefore, even if you start off with transsylvian, if you're going to achieve an optimal resection, you will land up later on having to resect that tumor in the opercular. So why not start from the opercular and increase your windows? The steps involved in planning with monitoring and mapping in insular glioma surgery starts with pre-op assessment of patients. It's always better to do neuropsychological assessment if you're going to do awake mapping. That gives you an idea as to which patients will be cooperative and also how to tailor your mapping during the surgery. But I think the most important aspect is understanding the anatomy and mentally projecting that onto the surgical field. Dr. Mazumdar has shown it very nicely. The insula is hidden under all the opercular, and therefore it's important to understand the insular anatomy. And from the surgical standpoint, it's these landmarks that are important that will guide you during your surgery. So you have the three sulci, the superior, inferior, and the anterior, and the overlying sylvian fissure, which is what you have to imagine when you open the brain and you have the exposed opercular and the sylvian fissure with you. Correlating the MRI with the surface anatomy, projecting the MRI onto the surface anatomy. With or without navigation, you can have the navigation or you could do it in your own mind mentally. And understanding how the insula underneath the cortex is going to be. Remember, a large part of the insula is going to be under the frontal operculum and a smaller part in the temporal. Of course, depending on how the tumor has grown, it could involve these areas very variably. One of the most reliable landmarks and which never fails is your anatomical surface anatomy and the craniometric points. From the insular glioma surgery point of view, you need to understand a few of them, and I won't go through all of these. All of us would know them, but these guide you as to the landmarks that are important for getting into the sulci of the insula. So these also have a correlate, as I told you, with the insula superior and inferior circular sulci or the inferior, superior and inferior insular sulci. When you're getting into the frontal operculum superiorly, as you go deep, you will hit the superior sulcus of the insula or the circular sulcus, the superior limb. And it's here that you realize that this will be your landmark, because beyond this, you will have the subcortical fibers, the descending fibers of the corona radiata, and you have to be careful and you have to start mapping subcortically. Similarly, the inferior limiting sulcus of the insula is a very important landmark because that's where you will find your M2s. And one of the surface landmarks for this is the superior temporal sulcus. As you go deep into the superior temporal sulcus, if you follow that plane, you will reach the inferior limiting sulcus of the insula. And the inferior limiting sulcus of the insula also is important because it leads you on to the isthmus, or what is called as the isthmus, or the I would say the stem of the temporal lobe, which is a very eloquent region where all the fibers cross over from the frontal along the Lyman insula into the temporal lobe. And this includes the inferior fronto-occipital fasciculus and the visual radiations or the optic radiations, which are crucial and which you have to preserve. So if you were to look at the substrates at risk when you're doing transopercular surgery, cortical would be all the opercular, the frontal, the parietal, and the temporal operculi. But very importantly, the subcortical fibers, not just the corticospinal tract or the frontoaslant, which you will encounter in the frontal operculum, but also the deeper associative tracts, including the arcuate and the IFOF, and as I said, the optic radiation. You can use functional MRI, you can use DTI to understand and to plan and guide yourself during surgery, but the best way to validate it is to intraoperatively assess the function. And not to forget deeper structures, which form the limits beyond which you will not extend your resection. The vascular anatomy is also crucial, and Dr. Mazumdar has already spoken about the long and the short perforators. How would you go about monitoring and mapping these intraoperatively? You can do that asleep or awake, both of them. Asleep allows you to map and monitor motor very effectively using MEPs, and is useful in insular glioma surgeries and should be an adjunct, whether you're doing transsylvian, transopercular, or even awake, you can use the MEPs. It requires a neurophysiologist or a neurotechnologist, and you require MEPs, of course, so you need a little bit more of an elaborate machine, whereas awake requires only a bipolar stimulation and somebody to monitor the function of the patient. The tasks that you would use during awake depend on whether it's the dominant or the non-dominant hemisphere, but generally includes number counting and a picture naming task and visual field assessment, along with MEPs, as I mentioned, which can be done both under asleep and awake conditions. So this is how we do it. This is, we prefer doing a sleep-awake technique using an LMA. I use navigation with DTI and also use ultrasound combined with the navigation most of the times. Bipolar direct electrical stimulation, low frequency is used for awake, but I also do the MEPs and put in a strip for all these cases, do a wide frontotemporal craniotomy, then awaken the patient, do the cortical mapping, identify areas which are non-eloquent, and more often than not, you'll have enough opercular entry points. You reset all that negatively mapped regions, identify superior, inferior, anterior limiting sulci. I'll show videos shortly. Define the subcortical boundaries, and then piecemeal resect the tumor, remaining in a subpial plane without handling the vessels in the sylvian fissure, constantly monitoring both MEPs and the patient if the patient is awake. This is the layout of a surgery for left-sided tumor. You would be standing at the head end with the neuropsychologist monitoring the patient. And we just flip that if you're doing a non-dominant, relatively non-dominant or right-sided tumor. This is what we do, sleep awake, put the patient on a horseshoe in the lateral position to make sure that the patient is comfortable before giving the patient sedation and putting in the LMA. With the patient on the horseshoe, the LMA is inserted. And then we give the pin side blocks, and in the same position, put in the pins. We do that because if you're using navigation, we don't want to give the scalp block till we finish registration. After this, we put in all the neuromonitoring adjuncts, we complete navigation registration, and then give the scalp block, drape the patient, do your craniotomy, and once you're done, you remove the LMA and awaken the patient and continue with your mapping cortically and subcortically. Other adjuncts that I would use include ultrasound and intraoperative mapping, subcortical and cortical both. Classically, you make multiple opercular windows, and hopefully we'll see that in one quick video that I have. The ultrasound, interestingly, also gives you the opportunity to do an angiography intraoperatively, and again, very useful, especially in the region of the insula, where you can see all the vessels. And if you're lucky, you will even see the lenticular striate vessels, as in this navigated ultrasound. Now I'll quickly go through this one video of a giant dominant-sided insular glioma in a young lady. As you can see, this was a tumor which was involving predominantly the anterior insula, sparing the posterior strip of the insula, which, like Dr. Datta mentioned, is often a very difficult site to resect the tumor from. So it was involving with a large part going into the frontal, deep frontal subcortical white matter, but largely limited to the insula, with no direct opercular involvement except for some amount in the frontal region. Interestingly, there was also some deep involvement in the caudate and the basal forebrain region, which is what I'd like to highlight here. So this is the region where it's going into the caudate head and the basal forebrain. And this is actually the region of the anterior perforating substance. Now, remember, I think for the transopercular, transsylvian, all approaches, this is a no-go zone. You cannot resect tumor in this region because it directly involves the anterior perforating substance. And in this case, our aim was to resect all the tumor, leaving this behind. You can do fMRI if you would like to, I do it, but it doesn't really have too much of a direct surgical bearing during the surgical resection. So this is the video of the patient. So just for the sake of understanding the anatomy, these are all the substrates at risk. The cortical, the motor strip, and the opercular, the gyri. And then once you have the tumor, underneath the tumor is the important subcortical structure, especially the external capsule, the IFOF, and then you have the basal ganglia structures. Further deeper to that are the ventral striatum and the other deep gray matter, which you would not resect, and that all constitutes the basal forebrain as well as the preseptal area and the anterior perforating substance. I'm sorry. So once we open the brain, we do the cortical mapping, and then in the negatively mapped area, we do multiple cortical windows. First, resect the cortex, and then identify quickly the posterior limit of your resection subcortically. The involved cortical opercular part can be resected subpially. And this is identifying the superior insular sulcus with the tumor in the insula seen here, but still covered by pia. And we are not going to damage that pia, but we will go around the superior insular sulcus and get into the tumor. Then you create another window in the anterior insular sulcus. And finally, one more window in the superior temporal operculum. And therefore, circumferentially, you isolate the tumor, the insular tumor, all the time being subpial, taking care not to damage the pia of the insula. And then, once you have done that, you can peel the tumor from underneath the pia gradually. You don't have to do it always in one piece. You can keep debulking it with either accusa or piecemeal. Often these are non-vascular, not like a GBM. And you continue doing that till you reach the depths of the tumor, where you will start doing mapping again, subcortical mapping, especially for the IFOF, as well as for the MEPs or motor, because that's where your fibers of the internal capsule will come. A very useful landmark is this nutmeg appearance of the lentiform, which is the limit, the deep limit of your resection, and guides your the surgical resection at this level. Once that is done, of course, you achieve hemostasis and ensure that your functional monitoring is all intact. This was the overall the monitoring and the mapping plan in this patient. And this is the post-op MRI of this patient, where we were able to resect the tumor quite radically, except for that part which was going into the caudate nucleus. The ones on top are the post-op scan, and below is the pre-op comparison. And I'll just show you this video. So this is what I meant by the part which is going into the caudate and into the basal forebrain region. which is where we left tumor as we had intended to. Sometimes it's not easy, and as Dr. Mazumdar also rightly pointed out, this is resection probability maps, which show that the red ones are the regions where most often you will leave behind tumor, and it all correlates with the posterior part of the insula or the zone 2 of the Berger-Sinai. In this cases, what you could do is add one more opercular entry behind the motor cortex into the parietal opercular area. And I'll just show one small video for a minute just to highlight that. So this was a large tumor with more posterior extension. Of course, you do your mapping, awake mapping, identify all the eloquent areas, and then identify all the non-eloquent windows. These are the non-eloquent windows. This is the parietal window behind the motor strip, which we will use at the end. So you go ahead, do all your opercular access, you remove the tumor from everywhere. As you can see, multiple opercular windows sparing all the bridging veins. And then this is the final extra parietal opercular access that is made. Careful, because you have the motor strip in front of you now, and gradually remove the tumor from underneath the insular pia. This helps you get one more angle of attack for this tumor, which is important because that is the one which is most inaccessible. This is what the post-op MRI showed in this case. So I would like to finally summarize by saying that the transopercular approach is safe, provided you do mapping and monitoring, provides a lot of surgical attack angles and more surgical freedom. The learning curve is short, technically less challenging than the trans-sylvian approach, which requires you to open the sylvian fissure. But mapping is important. And of course, understanding the microsurgical and vascular anatomy is crucial in this, as with the trans-sylvian also. With that, I'll stop and thank you very much.
Hello, Ranjit, are you there?
Yeah, thank you very much, Dr. Ali Asgar. Stupendous lecture. Now we invite Dr. Panigrahi from Hyderabad. Thanks, Dr. Panigrahi, for joining academics in Maharashtra. Welcome. We'll talk about the overall management strategies and comparison between both approaches and the complications. Dr. Panigrahi.
Yeah. Can you see my slide?
Yeah, we can see your slide. We can hear you also, sir.
Good evening. Thanks, Dr. Ranjit, for being to be part of Maharashtra Neurosurgical Society, and Dr. Kishore. I know Kishore for the past 32 years, more than that. And we joined residency together, but then he went off, and he did at Bombay and then went to UK. Dr. Dattara has already explained about trans-sylvian, and Ali has told about trans-opercular. I'll explain now what is better in my hands, the trans-sylvian or trans-opercular, which works out better in my hand. Insular gliomas are difficult surgery, and then complication in insular glioma is very high. So I'll be explaining how we avoid complication by deciding the approach, which case one should use a trans-opercular, and in which case a trans-sylvian is better. Like the now, if you get a case like this, how do you decide that to do a trans-sylvian or a trans-opercular? As you know that earlier, because the complications were higher, if you see in this paper, the complication rate post-op deficit has been to the extent of 10%, and including in hands of Professor Yasagil, the 5%, 5 to 10% Hence, many people, if you have a small glioma in the insula, they suggested observation rather than surgery. Observe the tumor. But then observing the glioma is contradictory to the present concept where early surgery is recommended. Not only the problems of deciding to operate or not, the type of histology also is controversy. Dufour et al., they said that all of them are low-grade glioma, but others many people have told it's half and half are low-grade and half are low-grade, higher grade, and some people have told it's 70% are low-grade. But the general tendency is most of them are low-grade, and so one has to be be aggressive in operating because so that one can avoid adjuvant therapy. If one can excise the tumor without any morbidity and mortality. There are a lot of papers discussing on the different approaches, trans-sylvian and trans-opercular. And this, if you see in this table, the surgeons who did trans-sylvian, including Professor Yasagil, the permanent deficit was almost 11% in the series he had published, as compared to those compared to trans-opercular, where Professor Dufa has published in 2009, his post-op permanent deficit was 4%. So and again, there was one paper in 2010 by Simon et al., where in trans-sylvian, they had a post-op deficit of 20%. So if one analyzes the incidence of complication in trans-sylvian versus trans-opercular, at least in the literature, the complications are higher in trans-sylvian rather than the trans-opercular. So how do you reduce this complication? The first management option is preoperative planning. As Dr. Ali explained, that it's always better to have a functional MRI and DTI, and then that can be translated by doing an intra-op testing during the surgery. We published our cases of doing functional MRI and DTI in our cases and compared with the cases which we had operated without that. And then this is what the results we found. We analyzed 81 cases, where in group 2, before 2014, we never did DTI functional MR. And from 2015 onwards, we started doing DTI functional MR for all cases. And when we, of all the 30 cases we did DTI, patients where they reported as that the tract was infiltrated, we planned subtotal excision. When they reported as that the tract was displaced, we planned an aggressive resection of the tumor. Like this case, again, the tracts were displaced. So we did functional MR and DTI, and we have operated all the cases under general anesthesia. We have done very few cases with awake craniotomy. And we followed this protocol of attempting excision when it's displaced and whenever it's infiltrated to do a subtotal excision. What do you do? The strategy is during surgery to have a better outcome, whether to do a trans-sylvian or a trans-opercular. Like this case where 50% of the tumor is in front of the foramen of Monro, or this case, which is where the 50% of tumor is behind the foramen Monro. Which case is a better for trans-opercular and which case is better for trans-sylvian? As Professor Dr. Dattatra has already explained, that Burgess-Hannay classification helps us to decide which is a better approach. So we follow the same to decide our approach. And the Burgess-Hannay classification, it depends on the line through the sylvian fissure and a line perpendicular to it through the foramen of Monro, and then divides the region of insula into 4 zones. So any tumor in zone 1 or zone 2 or zone 3 and 4, one can decide zone 1, 3 and 4. Normally we prefer a trans-opercular, but any tumor where it's in zone 2, we do a trans-sylvian. Now, why do we decide trans-sylvian? To understand that this is a surgical assessment of insula, and this paper has analyzed the exposure of the insula when you open the sylvian fissure of the different zone. If one can see here, the zone 1 tumor, zone 3 tumor, and zone 4 tumor, the exposure of the tumor is better in transcortical. This is what is anatomically found, that if you do a transcortical approach in these 3 group of tumor, the exposure is better. Whereas in zone 2, the trans-sylvian gives a better approach. The surgical window is better in trans-sylvian versus transcortical. You can see here. So this was the basis of deciding that zone 2 tumors we prefer trans-sylvian, whereas zone 3, 4, and 1 we prefer transopercular because transcortical gave a better exposure. That is what this is a cadaveric study. So if you're going back to the cases I showed, in this case, we did a transopercular, whereas here, where 50% is behind the foramen of Monro, which is a zone 2 tumor, we did a trans-sylvian approach. And as Dr. Ali said, that posterior part of the tumor one has to leave out, or you use another window through the parietal posterior part of the sylvian fissure. So whenever we did a trans-sylvian approach in zone 2 tumors, the first step is to open the sylvian fissure and identify the Lyman insulae, identify the circular sulcus, and then work in between the vessels and then tumor. The problem of doing this is a lot of manipulation of the vessels, so post-op deficits because of spasm can be higher. And the tumor is excised in piecemeal in between by the cortical, the vessels of the MCA, and the end point is the lenticular striate medially, what we have to identify. You can see here, once you open the sylvian fissure, these are the lenticular striate, and one has to remain superficial to that. That is a deeper plane. One should not go beyond the lenticular striate and remain in that plane and excise the tumor. Surrounded by the circular sulcus, deeper plane is by the lenticular striate. But when one does with a transopercular approach, one goes through the cortex and then excises the tumor. And here, identifying the deeper plane becomes difficult. And though we use navigation intraoperatively and then use stimulation also to identify the subcortical tract and also the change in the color and identify the vessels, perpendicular vessels. Once you reach the perpendicular vessels, we stop the excising the tumor that is in the deeper plane. And surrounding that, we use a fluorescent dye and then excise the tumor depending on the fluorescence of the infiltrated tissue. We also use ICG to look for the perpendicular vessels and stop the tumor. You can see the perpendicular vessel, and the ICG shows that the vessel is seen there, and that is where we end our extent of excision. In addition to doing ICG, we also use subcortical stimulation, and on the left side, we have done awake surgery. Of the 81 cases, 60% of them were low grade and 25% we had higher grade tumors, grade 4 tumor. In oligodendrogliomas, we have not given an adjuvant therapy if you have excised totally. In astrocytomas also, we have followed up without adjuvant therapy. In subtotal excision, we followed up with an adjuvant therapy. Like this patient of a grade 2 oligo post-op, no adjuvant therapy. This is a post-op scan after 1 year. This is again another grade 2 tumor. This was an astrocytoma, and as I explained, it was 50% of the tumor is behind the foramen of Monro. We couldn't excise totally. Hence, we gave adjuvant therapy, and this is the post-op scan at the end of 3 years. This is a grade 2 astrocytoma. Residual tumor was there behind foramen Monroe, and this is received radiation. And this is a scan at the end of 2 years follow-up. This is a grade 2 tumor. We could excise, and then this is a pre and post-op without an adjuvant therapy at the end of 4 years. And this is a grade 2 oligo, 3 months post-op, and it is 1P 19 correlated. So we decided to follow up the patient. This is a post-op scan, and the patient is still under follow-up without any adjuvant therapy. As grade 3 and grade 4 tumors, all of them had received radiation and concomitant chemotherapy. And this is a grade 2 tumor, pre and post-op 2 years after surgery. Grade 4 tumors. Grade 4, this is a grade 4 tumor, which is a post-op scan at the end of 6 months with radiation and chemotherapy. This is a grade 2 tumor, 4 years later came with recurrence, and this was an ill-defined recurrence. So we gave adjuvant therapy at the end of, we did biopsy. The biopsy had turned to grade 3, and then we gave an adjuvant therapy after second surgery. So when we compared with group 1 and group 2, the extent of deficit, immediate post-op deficit was 27% in the trans-sylvian, and in trans-opercular it was 10%. But the at 3-month post-op deficit had almost 0 in the group 2, whereas in this thing it was in group 1, where we had not used DTI, the post-op deficit persisted of 27%, that there was no change immediate or late post-op deficit. And we compared the transopercular and trans-sylvian. We had done 23 cases of transopercular and 38 trans-sylvian, and the immediate post-op complications was 34% in trans-sylvian versus 8.6% in the transopercular. And at the end of 3 months, the transopercular, all of them had improved, but a 10% in trans-sylvian continued to have persistent deficit. Among the patients of grade 2 and 3 of the overall survival, the grade 2 patients, 94% had 3-year 90% survival. Grade 3 had 75% 3-year survival. When I did a survival analysis, the grade 2 had a better survival than grade 3 and grade 4. Now, this paper, this is a meta-analysis of the surgical treatment of insular glioma, systemic review. They have analyzed 2,200 cases operated by both trans-sylvian and trans-opercular, which came in this year. And they have taken all the papers, including our paper, in this meta-analysis. And what they concluded was that the post-op deficit is higher in trans-sylvian. It's like 6.8% compared to, and post-op deficit was higher in trans-sylvian. Though they have told that it is mandatory to do one of the functional monitoring, either do a pre-op mapping and intra-op mapping which includes awake craniotomy is better. That's what is the conclusion. And they found some evidence that transcortical approaches had a lesser rate of motor deficit than trans-sylvian approach. In conclusion, resection of gliomas remains a surgical challenge. Preoperative functional MR and DTI would help in deciding the type of resection in insular glioma. Most of them are low grade, hence they should be aggressively treated. And transopercular is more has a lesser complications than trans-sylvian approach. And trans-sylvian is to be done in the zone 2 tumors. Thank you for your attention.
Thank you very much, Dr. Panigri. We have two expert panelists today. Dr. Shailendra Achwal, originally Maharashtrian, now residing in UK. He has joined us. And Dr. Matthew Abraham, whom we know all has great work in epilepsy and intrinsic gliomas. So I request both of them. First, I would ask Dr. Shailendra to make expert comments.
Hi, thank you. Thank you. It's actually my privilege to attend this webinar, and I have learned a lot myself from all these speakers. They are really fantastic presentations from Dr. Muzumdar, Dr. Panigrahi, and Dr. Aliasgar. And yes, it is a complex issue, no doubt about it, and that's why we are talking about it. One thing one should not forget is ultimately it's a glioma, and the final outcome will depend on the biology of the tumor. And that is something that we should not forget. And I also tell my trainees that the glioma treatment and pathology is evolving so much that what I tell you today may not be true in 5 years' time. The things have been changing. And exactly, I think one of the speakers mentioned that in the past, if it was just a low grade, we used to leave it alone, thinking that it's quite a complicated matter. We are talking about this insular glioma surgery, all different approaches and all. And yes, we might, I hope there will be some answer from the lab, and we might be treating these gliomas completely differently and much more effectively with much less complications in future. I have written down some points, and one of the things that I don't know whether in your practice how much you follow, but pregnancy and low-grade glioma is also one correlation which is mentioned, and I have observed that in my practice as well. So if a female in the childbearing age is there with a low-grade insular glioma, yes, the advice could be to avoid pregnancy. And because it has been observed very clearly that either they grow rapidly or they have a high rate of change from low grade to high grade. That's one point, and that applies to insular gliomas as well. I know that I'm having practiced in Aurangabad for 4 years before I came to UK. I know that the facilities available for neurosurgeons vary from center to center. And there are general neurosurgeons practicing in different areas as well who may not have all those facilities which Dr. Panigrahi or Dr. Aliasgar or everybody has. And they may think, is this in my capacity to do this insular glioma? And I don't know, I can ask this question to any of the speakers as well as to what do they think? Can this be done in areas where there is less facility available? And or Ranjit, if you want to take this at the end for discussion. In one of the one of those articles I read as well that should it be practiced only in the main institutions, particularly being a complex surgery? Anybody has any experience of a redo procedure for an insular glioma? That I don't have. I don't have any experience. Redo gliomas, particularly redo low-grade gliomas, are challenging. And if you're talking about an insular redo, it will be even more challenging because all the glasses and all the anatomical planes that you described, they are all sort of significantly reduced. So that will be my question to any of the speakers. As I said, I don't have any experience on that. Dr. Panigrahi, you mentioned about navigation, and I assume it's a standard either brain lab or stealth navigation you use. Is that right?
Yeah.
And how accurate do you think when you have done so much of dissection around, how much accurate do you think it could be?
Yeah, I mean, at the end of surgery, it is not accurate. It loses the accuracy. But if you try to start working at the periphery from the first, instead of doing internal decompression, you try to go all around the tumor. That's difficult in transsylvian, but when you do transopercular, one can go around the tumor. So there is not much of shift, and so it's accurate. But in transsylvian, it's not, it loses accuracy because you start with decompressing first. For transopercular, it has some accuracy.
Okay, good. And you also mentioned about fluorescence dye. Is that 5-ALA you use or?
No, 5-ALA is quite expensive.
Yeah.
So we use the yellow fluorescence.
Okay.
And yeah.
And is that useful for low grades as well?
It depends on the scan. If the scan finding has an enhancement, then it shows. It not doesn't work for all of the patients. But if the if MRI shows enhancement, then it enhances in the with yellow fluorescence also.
Okay. No, thank you. Those were my comments. But really, really impressive presentation from all the three speakers. Thank you. Ranjit?
Thank you very much, Dr. Shailendra. We request Dr. Matthew Abraham to share his thoughts and grand experience.
Thank you for the organizers for giving me this opportunity. Excellent talks by Dr. Majumdar, Dr. Ali, as well as Dr. Panigrehi. I had a few basic comments to make. One is ultimately an insular glioma is another glioma. And the root principle remains as maximal safe resection. Whatever is your safe limit, if you lose that safety, all the benefit is lost. The rule of the thumb, in my opinion, between transsylvian and the opercular is the rule of the thumb is if you are habitually opening the sylvian for an aneurysm from anterior medial to lateral, then the sylvian approach for an insular glioma may not be suitable for you. A surgeon operating on a sylvian with an intention to open around 5.5 centimeters has to translate himself into a very different plane of finesse when he starts opening. The finesse required for that does not come when you touch on the insular gliomas. It is probably developed as part of a dissection for aneurysms, maybe for MC aneurysms. If you're habitually opening from medial to lateral, then you may not be adequately positioned to go ahead and open the sylvian very radically. More than 85% of my cases have been operated through transsylvian. I've operated close to 150 insular lesions. I felt that if you can, first of all, it's the positioning. If you can position the patient in an antero posture, you should not turn the patient head too much. The trajectory will take you to the posterior insula. The second issue is if you can, there are a few anatomical landmarks which you have to identify. One is open it sufficient until you see the angular artery. If you can see the angular artery, you can remove the entire insular region. Second one is the first MCA perforator that you see. Once you see that, never go beyond that. The third thing is the marginal surface. You have to identify the marginal surface, but particularly on the frontal opercle. If you do not do that, you are in deep trouble. And the third thing is the nutmeg appearance, as Dr. Ali had pointed out, against the putamen is an extremely useful landmark. And once you have it, then you will not transgress any deeper. Now, my method have been to visualize the insula as a sphere rather than as a plane. And I know Dr. Majumdar and Dr. Panigrehi have a lot of experience in epilepsy surgery. Once you perceive the insula as a sphere, then you can subject the patient to a subpile transection. That is, you can go into the pile. Once you are in the subpile plane, as you approach a gyral lesion in epilepsy, the vessels will not come near. You are unlikely to interfere with any of the MCA vessels. And the total lesion can be collapsed in. and ultimately it will come out like like an extra-axial lesion. Now, the larger the lesion, easier will be the tackling of a insular glioma, as in most extra-axial lesions. Quite different from how you will approach any other intra-axial lesion. Now, the second thing is there are two radiological features that you have to look for. One is whether you have a clear straight line plane against the basal ganglia, against the putamen, and whether you have infiltration of the frontal operculum. Once you have infiltration of the frontal operculum, I think I will prefer to go through a trans opercular approach like Ali. If you have a straight line separating the putamen from the insular glioma, and the lesion is reasonably large, I think a radical approach is possible to the transsylvian. One more aspect I just wanted to tell for the juniors. Suppose you are in your first or second year after completing your post-graduation, you are getting a high-grade insular glioma. I will say high-grade insular glioma is one of the deadliest lesions you can tackle in the brain. It is better not make sure that the first insular glioma that you tackle is not the high-grade one. You may not be able to tackle the whole lesion. The lesion will swell, edema will come, and you may even kill the patient. So the low-grade insular gliomas perhaps have to be approached, and the surgeon has to evolve before going for the high-grade lesion, which is particularly dangerous. There is another aspect which Professor Yasagil's article has said about devascularizing the insular glioma by coagulating the small vessels on the MCA, which I have a feeling that may not hold much water currently because of the distal perforator rising from the MCA, which can give a devastating opercular, devastating corona radiata infarct. So no coagulation of any vessel by intention may be useful in insular glioma. You have to go in deep into the lesion, preserve all possible small vessels before you do. More than just the approach, my feeling is the deficits as well as the outcome is more grossly affected by your intent and extent of your research. And approach may not really matter. When you have a small lesion, particularly non-glioma lesion in the insula, particularly posterior insula, I have a feeling that a trans cortical approach is quite hazardous and difficult because of the dense functions. Whenever I have mapped for epilepsy, for the indication of epilepsy, I have found no useful window on the frontal operculum. But when mapped for a glioma, you will often get a window. This is all I would like to say. Thank you. Excellent evening, excellent talks, which maintain very high levels. Thank you so much.
Thank you very much, Dr. Matthew Abram, for your expert comments. We hope all non-Maharashtrian speakers and panelists join us from time to time to guide us and our juniors. The session is now open to discussion and questions. Anybody has any more comments?
I have a comment because before we forget about this thing, a small comment. Matthew mentioned about epilepsy lesions when we operate insular lesions for epilepsy. And yes, there is a problem there because if the lesion, it's a dysplasia. Now we are talking about dysplasia versus glioma, a low grade or high grade. And when I have not shown that video, but whenever we did an insular dysplasia, it is much more critical. Now I used MEPs and I was getting MEP at the posterior extent, posterior insular. Now I couldn't excise that because I was sure that if it was firing on the intra-op ECG, but I had to leave it for the sake of not getting a hemiparesis and it's quite different from a patient of insular glioma who has got some symptoms versus for seizure freedom. So there, but I must tell you that even though this patient had subclinical, interictal EEG showed that epileptiform activity was there, the patient was happy because the seizure intensity and frequency reduced to such an extent that I was trying to get from the patient that the patient would be unhappy. And on the post-op MRI, I could see that the posterior insular dysplasia is still there. But the patient was happy. Now, this is completely different scenario as what we talk about a proper low grade or a high grade insular glioma. So that's the answer to this thing, Matthew's this thing, my experience of small insular dysplasia. Second thing is we have to differentiate insular gliomas from perisylvian or a peri-insular glioma. But those are subset different. Now, what is an insular glioma? Whether we are talking about proper insular gliomas versus sylvian, perisylvian region gliomas is also because they can confuse. They can tilt the results here and there. So whenever we are talking about a certain set of pure insular glioma, pure insular origin, then yes, what we are talking has relevance. But when we say that the tumor infiltrates into the frontal operculum and beyond, and then into the posterior regions, I don't know whether that's pure insular glioma we are talking, or whether it's some related to the molecular typing grade. Thank you. These are my two comments. Anybody else?
Yeah, I think Datta, I agree with Matthew's comments. Actually, my strategy for general lobar gliomas is, as Matthew pointed out, once the tumor is decompressed, I go radically to get the blood vessels mainly.
Yeah.
Because then even if you leave a little bit of tumor here and there, you believe that you've taken the blood supply out, and then the tumor will infarct and you will achieve. I mean, I do Sylvian fissure dissection minimum once a week for aneurysms. And still, I find that insular gliomas through trans-Sylvian route is a challenge, because as an aneurysm surgeon, you are used to having a normal anatomy all the time and not hypertrophied or supplying vessels into the tumor. Where I struggle is that in aneurysms, I know that the perforators are there and they are not supplying the aneurysm body, and I can clip the aneurysm without worrying about them. In gliomas, I'm so tempted to take any hypertrophied vessel if they are going into the glioma surface. And then that's where I think the balance to be had, that if you're too radical, especially with the blood vessels, patient pays a heavy price. If not, you risk leaving tumor behind. So I think it is a very expert and niche area of neuro-oncology. And in our unit, we are 6 of us who do neuro-oncology and remove brain tumors, but actually there are only 2 of the 6 who specialize in insular gliomas, just to get more and more subspecialization and develop the expertise that one needs for this kind of cases. I'm sure, Shailendra, it's same for in your department as well.
Yes, Kishore, yeah. Means, first of all, not everybody does brain tumors in the department, as it happens in your case as well. And on the top, yes, we do sort of keep insular gliomas to one person. The big advantage, if at all, in India is that number of patients is quite a lot. So compared to UK, so you get quite a lot of cases to do, and especially as rightly Kishore said, this is a very niche area. You do more and more, and obviously you get better and better, no doubt about it. I'm actually glad to hear from Kishore, because Kishore is an aneurysm surgeon and I'm not. So in spite of being an aneurysm surgeon, if he's a bit worried about going through Sylvian, because I'm always a transopercular person. So thank you. Thank you. And anybody has the experience of redo opercular insular gliomas?
I have, I think I have done around close to 15 redos.
Oh, very good.
My feeling is, if you have opened the Sylvian widely, my own redos have been great majority of them. A redo was easier. A redo was easier because the one crux I just wanted to say about a re-exploration of any tube, that is, don't open the dura as it is, as in a convention. Don't try to expose and peel the dura out. Make an incision where you would like to enter. And virtually like a minimally invasive spine surgery, go directly into the lesion. And from inside, try to come out. I had to operate a girl, a movie actress 9 times over a period of 12 years for a glioma. She was acting until her 8th surgery, which she went back to. So actually, the same thing holds for an insular glioma. You can't manipulate the operculum a second time. If you can go directly into the sylvian from anterior, to the anteroposterior trajectory, the cavity will still remain. You will still get most of your prior cavity through which you can remove most of it. And perhaps maybe a shade easier than a first look surgery. Like somebody has operated on a vestibular schwannoma also knows that a relook is not that difficult. A redo vestibular schwannoma is not as difficult as a large giant first look vestibular schwannoma. Once you enter the cavity, you can work around.
Ranjit, can I ask a question?
Yeah, sure.
Yeah, thanks for the excellent presentation. My question is to Dr. Moyadi. How easy it is to subcortically map the IFOF and the arcuate fasciculus compared to a corticospinal tract? Because we always struggle to map these IFOF and the arcuate fasciculus, and apart from the corticospinal tract.
Yeah, I mean, I'm assuming you're saying that in awake patients, right? It is
Yes.
awake patients only.
Yes.
I think, yeah, arcuate and IFOF, actually, we use the picture naming. It's a very simple task. And you have to just map, stimulate, and you get a response. It doesn't matter if it's a phonological or a semantic. As long as the patient has a paraphasia, you assume that you are on one of those eloquent substrates. And the arcuate and the IFOF, at least in the region of the insula, don't overlap with each other. The arcuate is more in the perisylvian above, and the IFOF is on the limen or in the isthmus of the temporal, over the temporal roof of the temporal horn. And a better test to use would be the pyramid and palm tree test. Basically, it's an association, task of association, where you show 3 pictures, one of them correlating with the paired picture and the other one not. And we found that very useful, and that can be used both on the left and the right side. So my preference is to do awakes even for right-sided insular tumors, even giant ones. We do most of the insular gliomas, low grade, not the high grade, not the GBMs, but low grades awake. On the right side, what you're looking for is, of course, the motor and the IFOF in the depth, which is where you test for semantics. There, the picture naming won't help you. You have to use the PPT. So our awake paradigm is very simple. You have number counting, you do motor task, and you do the PPT. In between, your neuropsychologist or your anesthesiologist can keep talking to the patient and other tasks for monitoring. That is different from mapping. For mapping, we're just going to use the PPT or the picture naming. And it's actually, it works pretty well.
Thank you.
So any other comments, questions? So I have a question to Dr. Panigrahi. You said that your group 1, Transylvian, has almost 10% or 14% permanent deficits. So why do you think was that? Was it long perforators or was it lenticulostriate or transgression into corticospinal tract?
Most of them were before we were doing corticospinal tractography, and so those patients had deficit. So earlier, means I told our study is almost for 10 years. So we didn't have functional MRI tractography in the earlier cases, and so maybe infiltrated tracts we have tried excising, so we had a permanent deficit, and infarct because of lenticulostriate. After that, after doing tractography, we have become conservative in the cases where the tracts are infiltrated. And tumors which has involved zone 2 also, we have now learned that we should be conservative. That's how we reduced our deficit.
I just had to make a comment.
Let me make a few comments.
Yes, sir.
One is we have to be very, very sure
And we have to be completely aware that insular gliomas present with marginal or very subtle symptoms of epilepsy and things like that. It is now clear that radical resection is the treatment, even in low-grade gliomas, as we have heard. 15 years or 10 years ago, nobody used to even touch low insular gliomas. And now with the studies, various people have documented and shown that radical resection is good for the patient. It is good for the symptomatic relief. It is good for malignant transition is less. And ultimately, long-term survival is good, as good as cure, because they are low-grade, most of them. Now, the issue is they present with marginal symptoms of convergence and things like that, marginal. Any complication, any hemiparesis, any speech deficit, any complication can be absolutely devastating, because these people will live for 15, 20, 100 years as good as we live, but they will now live with a deficit. So no deficit is allowed, period. That is the bottom line of treatment of insular gliomas. Now you will ask me, what is the mechanism by which we can avoid any deficit? Because any simple deficit, any hemiparesis, any problem is a devastation for this patient. So one thing is, you should be very sure that you can remove, biopsy is not a treatment. You have to do radical resection. Bottom line, as even Matthew has said, and even Kishore has said, vascular preservation. You are not allowed to compromise even one perforator. Bottom line. You do a big resection, you do a radical resection, you have taken one perforator, you can land with a major deficit. So that is my experience, that you cannot compromise on any single perforator. That is one. Second thing is, anatomy of this region, as we have heard, is absolutely critical. It is not just gross anatomy, it is the deep anatomy, the white fiber anatomy. So important to understand and so critical to understand. And that forms the basis of resection. Whether it is transopercular, I see that transopercular is very popular. But you know what? I will try to avoid any normal brain if I can, even if it is in any area, even if it is in the frontal pole, I will not remove normal brain. Leave apart operculum. Opercular area is an important functional brain, even if by functional mapping, even if by cortical stimulation, you are not defining any kind of function there. I know it is very popular, but to remove a normal brain, this is in general. My understanding is, in general, we should not touch the normal brain. If we can enter the tumor by opening the fissure or whatever, we have to learn to open the fissure. And then what we have to do is, most critical in insular glioma is to identify normal from abnormal. Identify the abnormal and break into the abnormal. Break into the abnormal till you find the normal. So how to identify is one issue, and how to break the tumor is the next issue. How to identify normal from abnormal is the criticalest issue in this area. You see, if it is in the frontal brain, even if you go in the normal brain, it is okay. It's not okay, but it is acceptable. But in here, in this insular glioma, if you are removing the glioma and you are not sure where you are going and you enter into the normal brain, you can damage very devastatingly. So all this kind of understanding of anatomy, how the tumor is going, where the tumor is going, most important is your own eyes, rather than any kind of mapping, of course, function and all neuromonitoring, your own eyes, your understanding about the tumor, your understanding of the nature of color of the tumor, consistency of the tumor, and consistency of the normal brain. How to break into the tumor, these are very critical issues. Most important and paramount is you're not allowed to create a deficit in insular gliomas, because these deficits are devastation for the patient, who is now going to live a normal life with devastation. Even if you have not touched, that is better. If you don't know the anatomy, don't touch it. If you cannot save the vessels, don't touch it. If you don't know how to differentiate tumor from normal, don't touch it. So these are high-profile neurosurgery, ultimate apex of neurosurgery, and it needs everything that a neurosurgeon can possess.
and have in his experience, his talent, his everything combined, works on surgery of insular glioma. These are my few comments, my dear Ranjit. And all in all, insular glioma.
Thank you very much, sir. I can see Dr. Adi Asgar's expressions change. Mapping and
Ranjit, let me tell you, Ali is doing focused work. Ali is doing beautiful work. I love him as a human being and love him as a, everything that he does. But, when I have to give my comments, I give my comments. I don't get impressed by personality. Of course, Ali is my beauty. I work with Ali in Tata Hospital. I am also in Tata. I see his work. I discuss with him daily. But we have to keep our own views. Ali, I want your comments.
yeah, we all look forward to you both for learning.
I think Ranjit,